This session covers pharmacist staffing ratios and panel sizes, the benefits and drawbacks of using a virtual versus a local pharmacist, how pharmacist salaries compare to mid-level providers, and the current market landscape for utilizing pharmacists in primary care. A question I often receive when talking about this topic is the ideal staffing ratio between pharmacists and physicians. Unfortunately, there isn't a standard for pharmacist-physician ratio. It highly depends on the disease states the pharmacist is allowed to manage and what disease states they have more often. One anecdotal point to share, for a continuous glucose monitoring program, a pharmacist I know uses one pharmacist for about every 15 providers. And that's her experience with her population, but this will depend on the risk level of your population you have. Similar to staffing ratios, there's minimal data out there on pharmacist panel sizes and its impact. There was a study run to estimate panel size per full-time equivalent, FTE, utilizing the National Health Interview Survey. Their secondary objectives calculated the ideal FTE based on provider to pharmacist ratio and determined the impact of pharmacist panel size on patient access and quality metrics. The results showed that actual panel sizes were usually less than calculated, but the secondary outcomes indicated that each site was understaffed and overbooked. So maybe that's not necessarily surprising, or maybe they really need to tweak this algorithm. Speaking to pharmacists in these roles directly has illustrated that, similar to staffing ratios, it can vary dramatically based on disease states they're allowed to manage and what type of disease states they're seeing more often. For example, the panel size is larger for an anticoagulating clinic because the appointments tend to be much shorter. For disease states with more medications that are more complex, the initial appointments can be 1 hour, and then follow-up appointments can be 45 minutes to an hour, depending on how frequently they're coming in. For the continuous glucose monitoring program I mentioned earlier, the patient panel size is 300 since it involves office visits and billing. However, her program overall currently has 65,000 attributed lives that they drill down to find the patients that are high risk or missing gaps in care. They use pharmacy residents and pharmacy students and then pharmacy technicians to support this large panel size. Pharmacists have been in call centers or even a virtual Uber-like model with Aspen RX for several years. However, these are typically for one-off interventions like an annual comprehensive medication review or CMR. The pharmacist doesn't really build long-term rapport or maintain a relationship with the patient. It's a fee-for-service model where the companies outsource their MTM therapy, medication therapy management, or specific campaigns to these external pharmacists, often to check a box that they have a pharmacy program. However, I don't see a reason that pharmacists couldn't stick with the same patients virtually, like a virtual primary care business model, but I haven't seen it done as far as I know. This leaves a couple other options for utilizing a pharmacist for routine primary care. Hiring an employee pharmacist, which doesn't have to be a full-time employee at first or ever. Pharmacists are often fill partial FTEs across multiple clinics, so you don't have to have a full pharmacist if you don't have that many patients to support that yet. The second option is outsourcing to a local community pharmacy that can be trusted to do the primary care activities. Many pharmacists and community pharmacies have the clinical skills for this, but aligning the financial incentives can be difficult when pharmacies receive the majority of their revenue from dispensing and very little to none from their clinical services. So if you can set up a CPA or other arrangement, you could be using local pharmacies as touch points for your primary care practice. Here I want to take a look at the salary for pharmacists compared to mid-level providers that are often working in clinics. The main one to highlight is the salary for pharmacists in physician offices under the non-retail section there, $142,000 in 2023. The general trend is the more clinical positions are often earning higher salaries. Here you can see how salaries have changed over time for these positions, while retail and hospital positions have been pretty consistent the last several years and are seeing pretty flat salaries. Has been increasing demand for pharmacists in physician's office and really in overall more clinical positions. To compare against the pharmacist salary, the mid-level provider salaries are a little lower on average, with the physician office salaries below the overall average for these providers. You can pause here if you want to look more and spend more time looking at this breakdown between the practice sites, but I just wanted to show the difference between the pharmacists and these mid-level providers. A few examples where different players in the current market are using pharmacists in primary care. First, and nearby to me, Community Care of North Carolina is the largest and longest running medical home system in the US. Pharmacists joined the CCNC network teams in 2007 due to an increase in high risk, blind, aged, and disabled patients with diverse medication profiles and prescribers, making them particularly prone to multiple medication related problems. The network pharmacy goals emphasize improving global patient outcomes and decreasing overall healthcare costs. Over time, the pharmacists and CCNC have proven their ability to help reduce overall healthcare costs and decrease patient hospitalizations. Now, some details. Most CCNC networks staff at least one full-time network pharmacist and a clinical pharmacist. These pharmacists manage highly complex patient populations and focus on improving healthcare outcomes. Pharmacists' primary responsibilities include education, medication management services, coordination, rollout, and oversight of the pharmacy benefits. The network pharmacists spend about 40% of their time completing clinical tasks, whereas the clinical pharmacists spend about 95% of their time on clinical tasks. A network pharmacist is an employee of the network and is based within the network office. Pharmacists, nurse care managers, and physicians all work together to help provide patients the best care possible. Nurse care managers can gather the patient's reported list of medications as well as their bag of actual meds for a medication reconciliation that's reviewed by the pharmacist afterward. A pharmacist's comprehensive medication review, CMR, is reserved for patients who are more complex. Pharmacists review the med recs completed by care managers and perform their comprehensive medication reviews to communicate medication issues to the patient's primary care provider with the goal of improving the quality of care, reducing preventable hospital readmissions, and ED visits. The medication management is the main focus of the clinical pharmacist activities and is performed for both transitional care and targeted chronic care patients. Transitional care med management focuses on the identification of medication list discrepancies and updates after discharge from an acute care facility so they can take the correct regimen when they return home. Chronic care patients are identified and referred for med management by their care manager, their primary care provider, or a pharmacist directly involved in the primary care practice. Each patient is part of a pharmacy home. This gives pharmacists and care managers access to pharmacy data, the progress notes, lab data, med history, and other patient information to help recognize potential drug interactions, declining health from adherence issues, or any polypharmacy or drug cost issues. After a hospital discharge, the primary care providers are faxed a copy of the patient's med rec for use during the patient's follow-up visit. CCNC continues to highlight the pharmacist's work as both important and valuable to the providers. Second is the University of Michigan, the medical group that implemented the hypertension program mentioned in session 4 that saw great results when the pharmacists were incorporated in primary care. They've been embedding pharmacists in clinics since 2009. They published a study on one of their programs called the Michigan Pharmacists Transforming Care and Quality Collaborative. And in this study, across 17 different physician practices, 27 pharmacists participated and completed 24,000 patient encounters with 6,000 patients with an average of 5 visits per patient with diabetes and two visits for hypertension patients. The pharmacist made 15,000 therapeutic medication changes during the visits for diabetes and hypertension, with about 70% related to efficacy. The pharmacist also completed 4,200 CMRs for 3,000 patients, and during those CMR visits, 1,300 therapeutic changes were recommended. Along with problems with medication costs that were identified in 13% of the CMR visits, the blood pressure and A1C levels decreased in patients managed by the pharmacist, and out of 157 patients surveyed, 87% rated their pharmacist care as excellent, and at the end of the program, 16 out of the 17 physician offices retained their pharmacists even without the program funding. The funding ran out for the program, but the physicians still decided to keep the pharmacists on and pay their salaries themselves because they saw the value there. The VA has also been utilizing pharmacists for primary care for decades. Through a multimodal approach, a team at the Madison VA positioned their pharmacist providers to offload 27% of the primary care provider appointments, increasing referrals through education, improving the team satisfaction, and saving primary care providers 20 minutes on average for new patients, who were then able to reallocate their time to necessary patient care instead of spending it with those intros for the patients. Finally, multiple countries like the UK and Canada are already using pharmacists routinely in primary care. I'll talk about that more in session 8. This session covered pharmacist staffing ratios and panel sizes, the benefits and drawbacks of using a virtual versus a local pharmacist, how pharmacist salaries compared to mid-level providers, and the current market landscape for utilizing pharmacists in primary care.